And so what I have done here is to kind of lump together a few remaining topics that I think we need to address to be fairly complete about our coverage of the shoulder. What I'm going to do in this period of about 40 minutes or so is to discuss particularly the biceps tendon, also a bit about the rotator interval and problems with the rotator interval. And then again, to be complete, I've decided to throw in maybe 3 or 4 miscellaneous conditions. I apologize that we haven't covered everything related to the shoulder. We have not addressed tumors about the shoulder, but there's just so much we can accomplish in the period of time that we have. So let's look then at some of these other problems. The first thing that we're going to discuss fairly briefly is the problem of tendon calcification, since it occurs most commonly in the tendons of the rotator cuff. As you all know, this is extremely common. I'm told often by the fellows who come to our training program each year that they see more calcific tendinitis on the West Coast, far more than they saw in other portions or parts of the country. And I'm beginning to think that is true. I don't know exactly why that is, but we see so many cases of calcific tendinitis. Now, what one of our jobs is when we appreciate the calcification is try to determine whether or not it is symptomatic or asymptomatic. And of course, this was always difficult by plain film. The more discrete the calcification, perhaps the less clinically significant it was, but it was always difficult. So you could make an argument that MR imaging might be required if you see calcification on a plain film, just to determine whether or not it might be the source of the pain or there is some other source of the pain. And I'll show you what I mean about that in a few moments. The pathogenesis, not entirely clear. Degeneration or inflammation among the theories, ischemia. There clearly is a genetic predisposition in some reports. I want to remind you that calcium hydroxyapatite is the typical crystal associated with most cases of calcific tendinitis. But the calcium pyrophosphate crystals, as we've already shown, can be deposited in tendons so that you can get tendon calcification related to pyrophosphate crystal deposition. I believe, and I think it has been reported, that the calcifications related to pyrophosphate are different in appearance on plain films. They tend to be longer and more linear as opposed to globular calcification that is characteristic of hydroxyapatite crystal deposition. Here, the typical example that we see, of course, involvement of the supraspinatus tendon close to its footprint. Now, I can recall my introduction to looking for rotator cuff tendon tears was, in fact, standard arthrography. And at the Hospital for Special Surgery in New York, we had a real expert on it, Robert Freiberger, who really was one of the people who introduced standard arthrography. And I can recall at that time that we would always get a plain film prior to doing a shoulder arthrogram. And if the plain film showed calcification, the arthrogram was canceled, because at that time it was the belief that there was a disassociation between calcific tendinitis and rotator cuff tendon tears. Well, I think that thought has been dispelled through the years. I don't know if there's an increased likelihood of tearing, but clearly tears and calcification may occur together. And when we look at these calcifications, then, how do we know whether or not they are symptomatic or asymptomatic? It is my belief that most of the calcifications we see isolated to the tendon are asymptomatic, and that it is the movement of this calcification in a variety of directions that is associated with inflammation and significant clinical manifestation. The movements that take place, we could probably divide into 3 major ones. The first one would be more superficial, as shown in the diagram at the top right, What can occur with calcifications originating in a tendon? They can extrude from the superior surface of that tendon and be displaced either beneath the bursa or within the bursa. Here, perhaps beneath the bursa in this example. It is, I think, this movement, sometimes which occurs very quickly, that can be associated with inflammation. Look at the example here where we had calcification likely extruded from the subscapularis tendon lying in the area of the bursa anteriorly with a lot of inflammatory reaction. So if on a plain film you had seen the calcification and you got the MR, I think you would feel pretty good to suggest that the calcification was the cause of the shoulder pain in this particular person. There's an extreme inflammatory response. The second direction that the calcification may follow is inward, and the inward, of course, would be into the greater tuberosity. You may have seen cases like this where the calcification enters the bone and creates an area with extreme inflammatory reaction, edema. The diagnosis could be difficult if you were looking simply at this particular image, but if you can find the hydroxyapatite crystal elsewhere, then I think you'd be fairly comfortable suggesting, in fact, that that is intraosseous extension of the calcification. And this interesting case that several of us here know very well. It came from a well-known bone radiologist, and it was, in fact, his shoulder. And he had extreme pain and got plain films followed by CT and MR and saw this lesion within the greater tuberosity with hazy density, a lot of inflammatory reaction. And of course, being cautious, he raised the possibility that this could be a chondroblastoma. Nearby was the clue, I think, to what was going on. It was the calcification in the nearby tendon. So, he certainly felt that this could also be calcification, and that's what we thought it was. And over the period of the next 3 or 6 months, through approximately 10 studies, both CT and MR, that he got sequentially, the calcification went away and the pain disappeared. So this is intraosseous extension of calcification. And then the third direction, which is not as well known, is this, and that is inward along the tendon toward the myotendinous junction. We have several of these examples now. I suspect they're associated with delaminated tears, but I don't know which comes first. I think I favor the calcification dissects and therefore creates tears, but look at the degree of inflammation in the muscle. This clearly would be a cause of pain. This is the supraspinatus. Here's another. Look at this example where you can see the calcification extending along a delaminated tear. The second general condition that I would touch upon but briefly is adhesive capsulitis, going by a number of other names and associated with some predisposing factors that are listed on this slide. The disease can be on one side or it can be bilateral, and it has inflammatory and non-inflammatory stages. Many orthopedic surgeons believe they can make the diagnosis clinically, and they're probably correct. So I'm not sure there is a real place for imaging studies in making the diagnosis, but I'll show you examples. If, in fact, they make the diagnosis, one possible means of therapy is to take the patient to the operating room and under general anesthesia, manipulate the shoulder and break up the adhesions. Now, I haven't watched what happens, but I've seen MR exams like this following such manipulation. And there are reports in the literature of the damage that can be created because of the manipulation in the operating room. This report is a very good one, talking about capsular rupture, slap lesions, and ligament tears following manipulation of the shoulder. Here is an example of one that there was clearly a defect in the axillary pouch, as you can see here, and in the area of the rotator interval. And I can't prove this happened because of the manipulation, but it was attractive to think so. So because of that, in fact, you may want to consider options to this surgical manipulation. The option that can be offered by radiologists has been described in the literature as the Briesmont procedure. First, using arthrography or some other technique like MR, you establish the diagnosis by a restricted joint capacity as shown here, and then slowly you inject a solution which has indeed some pain medication within it, and you distend the joint until it eventually ruptures. Now, this may take time because initially you may only be able to get 5 milliliters of fluid in the joint, and then you have to put 2 more in, let 1 out, put 4 more in, let 2 out. And so we've learned as faculty that it is better to send a fellow in to do this procedure than a faculty. And indeed, what we often see in the fellow's hand is something like this, related to the syringe. There's a great deal of energy required to get this material in there. But once you're done, you send the patient for physical therapy, and you keep doing that. If you forget the physical therapy, this procedure won't work. And even if it works, I think we've had some patients who've come back a second or third time every few months to have this done. So this is a choice. With MR imaging, there are established imaging findings of adhesive capsulitis, including fibrosis, particularly in such sites as the rotator interval shown here. Around the capsule, one nice place to look is deep to the subscapularis muscle and tendon. In this case, there's also areas of capsular fibrosis about the subscapular recess. One of the most important target sites, according to arthroscopic observations, is the area of the rotator interval, where fibrosis with or without inflammatory change can be seen. It's easier to diagnose this condition when there is inflammation, as in the case I show you on the left, because of the high signal within the rotator interval. And whenever you're evaluating rotator interval and you're trying to figure out where it is, the best thing to do is follow the biceps tendon. The biceps tendon passes right through the rotator interval, and so you can follow it as it goes along its way in that interval. Here's another example, the second target site that we like to look at, and that is the area of the axillary pouch. And as the fellows know who are here, I love the transverse plane looking at the lower images because often that is the most evident place to find the signal in the axillary pouch. So that's an example. And then, of course, one can use intravenous gadolinium if one is not certain that there is inflammation. Here, a dramatic example of extensive inflammatory reaction. Diagnosis is adhesive capsulitis. One further example, rotator interval enhancement. Again, look at that finding in the area of the axillary pouch. The third general abnormality I'll briefly touch upon are intra-articular bodies. I mentioned earlier in this course that in fact they seek out depressions and recesses and dependent portions. In the glenohumeral joint, that would be the subscapular recess, the axillary recess, and the bicipital tendon sheath in the bicipital groove. This is a nice example that I used to show to the residents, asking them what was going on, and I would always get the same answer, that it was carcinoma of the prostate metastatic to bone, which is not an unreasonable answer, but the answer actually was a large intra-articular body within the subscapular recess of the glenohumeral joint. And by the way, look at this retroversion, that it's acquired retroversion, not developmental, with loss of bone stock and subluxation of the humeral head. Bicipital tendon sheath, you may in fact see large bodies that get in that region, and here's a recent case that we had with such bodies. Synovial cysts are not common around the glenohumeral joint. What is common, of course, are ganglion cysts. And these ganglion cysts shown here may become large. They arise from tears in the labrum, and they can extend down this one into the quadrilateral space where they can do damage to a nerve. This is the best synovial cyst of the glenohumeral joint that I have seen. It was sent to me by Doug Goodwin not too long ago, patient with rheumatoid arthritis who presented with a mass about the shoulder, large, complex synovial cyst, but I think these are not that common. Having said that, I show you a case that was shown to me on a film panel, and this, I'll let you look at it a moment. It was about I would say 15 years ago. And I'll give you the history that I was given. I was told this was a beautiful woman who lived on the beach in Southern California. So I said, well, this looks pretty easy to me. It's, a prosthesis, right? That's what I thought, but I don't know the signal intensity of that. Then they gave me the rest of the history. Beautiful she was, but she was unfortunate because she had developed systemic lupus erythematosus. She couldn't go out in the sun. She had had total hip replacements, total knee replacements, and had developed a horrible shoulder that was related to osteonecrosis and secondary septic arthritis, and had developed a mass on the anterior chest wall. During this time, she had had dialysis for her renal failure. So it turned out that this was, in fact, a synovial cyst that had originated in this glenohumeral joint that had extended over the chest wall and eventually actually produced a sinus tract that extended to the skin surface, draining amyloid. So the final diagnosis was amyloidosis and a synovial cyst. I didn't do very well on this case, nor on any of the other cases on that film panel. Let's move on and talk about the bicipital tendon in the remaining period of time. And because this is a complex area, and some of the concepts that I'm going to mention are going to be a bit difficult, and I'm not sure all of them are practical, but at least to be complete, I would do it. This is a slide illustrating the origin of the long head of the biceps tendon from the scapula. And as you all know, it typically has an origin that includes the labrum and a supraglenoid tubercle, so a bone and soft tissue origin. But there are many exceptions to that have been described, many variations. It may only have a bone origin. It may only have a labral origin. It is suggested that there are two different types of histology within the joint. The traction zone, there is typical tendon histology, and once you look at the sliding zone, that is the portion within the bicipital groove, the histology changes somewhat, and there are at least some fibrocartilaginous elements. When orthopedic surgeons do arthroscopy and want to evaluate the biceps tendon as best they can, they put a probe around it, as shown here, and they pull it, parts of it, into the joint that otherwise would be invisible. So this is a method of at least seeing a little bit more of the biceps tendon than you otherwise would. Now, if we go ahead and look at the true anatomy, and this surprises some, but the true anatomy of this biceps tendon, it is intracapsular, but it is extrasynovial. So it does not truly lie within the joint lumen in the vast majority of cases. This is covered by a synovial membrane that invaginates from the capsule and in most of us extends around the biceps tendon, but it is so thin that if you tell your orthopedic surgeons that that's not really in the joint, that there is a synovial lining, they won't believe you. Indeed, that is why you get strands like this when you look at the biceps tendon and the level of the bicipital groove. These are the infolded synovial membrane that now surrounds a lot of that tendon. So intracapsular extrasynovial. And that explains also when you do an arthrogram why the contrast doesn't just fall from the end of the sheet, because it is in fact a extrasynovial structure. Anomalous insertions of the biceps tendon are well recognized. This, we were fortunate to find, this was in a cadaver that we were looking at, part of a shoulder course here in San Diego, and we found this biceps tendon that appeared to terminate proximally in the capsule. When we went ahead and looked at the specimen, indeed, that was the end of the biceps. It never reached the glenoid. So a variety of anomalies have been described. Most of them are not diagnostically challenging, except this one. This is not an uncommon finding, and it represents a second biceps tendon, often seen best in the area of the bicipital groove. Now, this one is very flat, okay, but some of them are more circular and closer to the surface of the main biceps tendon. So when you first look at these, and this happens to us a lot, it looks like a split tear of the biceps tendon. Very easy to call it that. So the only way to prevent that particular mistake is to follow it up, because this accessory tendon often goes high above the humeral head to attach to the supraspinatus tendon or some other superior structure and doesn't curve toward the glenoid. How many of you have seen this? Yeah, this is a tricky thing. And I will bet that you, like I, have made mistakes calling these split tears of the biceps tendon within the groove. Now let's turn our attention to the rotator interval, which is this space located between the supraspinatus and subscapularis tendons. It's bordered medially by the coracoid process and laterally in the area of the biceps pulley, where it dives down the biceps into the bicipital groove. If we go ahead and take away that yellow, we can see the rotator interval capsule, which indeed is this area, and we can see, in fact, that some of the structures within the rotator interval that we introduced before, the coracohumeral ligament, the superior glenohumeral ligament, and the biceps tendon. I showed you one of these images before. This one of the structures located within the rotator interval. Now, tears of the rotator interval capsule are seen, and they are of debated clinical significance. There are schools of thought that say they are incidental. There are schools of thought that suggest they are significant because the rotator interval does provide stability to the glenohumeral joint. These are very hard to identify, and what you're looking for, and I've found these mainly with MR arthrography, is that there is communication between the glenohumeral joint and the subacromial subdeltoid bursa, but that communication is not through any of the tendons. So when you do the arthrogram and start looking at the images, your initial reaction is full thickness rotator cuff tear. And then you look around and you say, wait a minute, I can't find the tear. If that's the situation you find yourself in, you should go back and look very, very critically at the rotator interval. In this particular case, that was the site of communication. And all you need do in these cases is follow the biceps tendon, and it will lead you to the area that you want to examine, here a rotator interval capsular tear. Now, one of the problems, and I didn't mention it, is the same findings may be seen when there has been prior arthroscopy, because they go ahead and put a scope through the rotator interval. I do not know how long the communication will persist. And the same findings may occur if a rotator interval approach has been used for the arthrogram. So those are two things you have to think about. The main thing I want to cover in the remaining time relates to the instability of the biceps tendon. So on this slide, I'm indicating some of the structures that have been touted as important stabilizers of the biceps tendon, some representing stabilizers of that part of the tendon in the area of the rotator interval, and others representing structures that are said to be important in the stability of the biceps tendon lower down in the bicipital groove. But there is some disagreement as to the importance of each of these structures. Taken from the literature, this very nice diagram that we're going to use now as the baseline as we build on it. This is a diagram that is showing you the relationship of the biceps tendon, and it's this structure, as it arises from its anchor and passes over into the pulley and bicipital groove, and two other structures, the black area representing the coracohumeral ligament, and this kind of striped area representing the superior glenohumeral ligament. And you can see as we proceed outward that these structures become intimate as we reach the pulley. Now I'm going to go ahead and try to color code this as we look at this in more detail, and I'll begin by using this diagram and modify it in a few minutes. So this is kind of what things look like based upon the descriptions in the literature. A coracohumeral ligament here, mainly located above the biceps tendon, below it mainly the superior glenohumeral ligament, and then the greater and lesser tuberosities shown on the side. So this is the biceps sitting at the top of the bicipital groove. Michael Stadnick did these magnificent displays on a computer. And you can see here the biceps tendon, and he's trying to show the relationship of the coracohumeral ligament and superior glenohumeral ligament as these structures reach the bicipital groove. Now let's add to our drawing the supraspinatus tendon, which is attaching mainly to the greater tuberosity, and the subscapularis tendon, which of course attaches at least in part to the lesser tuberosity, so we'll add those to our diagram. If we go ahead and do a section in a cadaver, we can actually see some of these relationships. This is the supraspinatus tendon. This is the subscapularis tendon. Here's the biceps. And as you look at this, you can see there's considerable tissue on either side of that biceps, independent of those tendons. Presumably, and I think has been showed pretty well, these are limbs of the coracohumeral and superior glenohumeral ligament. We have done some anatomic studies, actually the research fellows have, and this is taken from one of them to indicate that if you look closely, you will find something anterior to the biceps tendon between the greater and lesser tuberosity. And our research fellow who did this said that this was tendon. That is why there is the theory that the subscapularis tendon sends fibers over and under the biceps tendon from the lesser to the greater tuberosity. That's kind of what we are seeing here. And if you look at the sagittal images, you can see the relationship of the superior glenohumeral ligament and coracohumeral ligament, which kind of form this arc of tissue just as the biceps plunges into the bicipital groove, again taken from his research. So let's go ahead and look now at this particular representation and talk about tendon stability and instability. I've changed the configuration of these structures, but not their location. Coracohumeral ligament, superior glenohumeral ligament with medial and lateral limbs here, the biceps sitting in the middle, lesser tuberosity subscap, greater tuberosity supraspinatus. And to this diagram, we have to add some fibers that I just showed you, tendinous fibers, presumably some of them subscapularis, others of them supraspinatus, that cross over and under the biceps tendon sitting within the groove. So this is kind of the diagram that I have in mind, particularly when I look at our axial images and trying to determine about stability of the biceps tendon. There are two major restraints to medial dislocation of the biceps tendon at the level of the biceps pulley. Those are the medial limbs of the two ligaments and the subscapularis tendon. So those are the medial stabilizers in this area. Disruption of both the medial limbs and the subscapularis tendon is required for medial dislocation of the biceps tendon. So both of these stabilizers have to be disrupted. Disruption of either the medial limbs or the subscapularis tendon allows medial subluxation of the biceps tendon. So those are the rules that govern the patterns of displacement that bring us to this particular slide that indicates subluxation, extraarticular dislocation, and intraarticular dislocation. With subtle differences, there are 6 patterns of displacement of the biceps tendon. 2 patterns of subluxation, 2 patterns of extraarticular dislocation, and 2 patterns of intraarticular dislocation. We're going to show you examples of all 6. I don't want you to get discouraged, particularly with some of the earlier ones, because they are very difficult to diagnose, and as I mentioned earlier, misdiagnosis may occur because of the normal shift of the biceps tendon within the groove during external and internal rotation of the shoulder. Accurate diagnosis will depend not only on the primary findings, but on the secondary findings. And the major secondary finding in the acute situation is going to be edema centered superficial to the biceps tendon at the pulley, as shown in this example. Type 1 pattern is one of the subluxation patterns. This relates to a tear of the subscapularis tendon alone. So we go ahead and put in the tear. What can occur when we have this sort of tear of the subscapularis is a distortion of the medial limbs, allowing very subtle displacement of the biceps tendon toward the lesser tuberosity. Now, that would mean that any asymmetry of the biceps tendon at the very top of the bicipital groove, you have to look at and try to decide, do you think it is physiologic or do you think it is pathologic? Here's an example of one that would fit into this category. There is tearing, although not high grade, of the subscapularis. This is the top of the lesser tuberosity, the first evidence of a bump. And here is the biceps tendon, which is subtly displaced medially. And as we go to our coronal image, here it looks like that's the edge of the biceps. This is the edge of the lesser tuberosity. This is consistent with a type 1 pattern in that the tendon is definitely torn. The type 2 pattern is the second pattern of subluxation, and it's the opposite. The subscapularis tendon is intact, but the medial limbs are torn. So that would be kind of what is going on, and the biceps can shift in a subtle fashion to lie alongside that lesser tuberosity. I have no proven cases of it. I'll give you an idea of what they should look like. Now, this is a bit misleading because you can see that there is a medial position of the biceps tendon, but we're a bit too high. You have to go a little bit lower to truly evaluate where the biceps is. Clearly, the biceps has to travel through the joint to get over to that top of the groove. So that always looks medial. The only reason I still include it, it looks like in the coronal plane that a portion of that biceps overlies the lesser tuberosity, and in this case, we did not see a tear of the subscapularis, but this is not a great example of the type 2 pattern. Now things get a little bit easier. The type 3 is an extraarticular dislocation related to tears of both the medial limbs and the subscapularis. So we go ahead and put that tear in. Now you can see how the subscapularis shifts more medially. It doesn't get into the joint, because there are some intact deep fibers of the subscapularis. So what does this look like? Diagrammatically, this is what it looks like. The bicep slips into this particular delaminating tear of the subscapularis, lying outside of the joint. The superficial fibers of the subscap perhaps are detached from the lesser tuberosity, but continue over to the greater tuberosity. Here's an example. You can see some of the fibers here going over to the greater tuberosity. Here are some other fibers here. There's the biceps tendon sitting in the groove, no longer here. This is consistent with a type 3 extra-articular dislocation. Here's another one. Here's the biceps. We can see those superficial fibers going over to the greater tuberosity. Here are the deep fibers. This is sitting within a delaminating tear of the subscapularis. The type 4 is the second pattern of extra-articular dislocation. This is the pattern in which the biceps tendon travels the furthest. The problem is mainly on the lateral side, where we rip the ligament and some of those crossing fibers right here. Now the biceps makes a long voyage, ends up medially, sitting in front of an intact subscapularis tendon. For this to occur, there has to be a tear of the supraspinatus tendon. To show you what this looks like, this would be a picture of what could happen. Anything overlying the groove would have to be disrupted, perhaps this being an early sign. The biceps sitting in front of an intact subscapularis. Here's an example of just that. That's the biceps tendon, the yellow arrows. This is the subscap. You can see it better here, intact, deep to the dislocated biceps. It is not intra-articular, it is extra-articular. Here's another one. It is dislocated medially. This is the subscapularis. All right, here is the biceps. This is subscapularis, dislocated. In fact, normal-looking subscap, extra-articular position. And then finally, the two types of intra-articular dislocation. The first of these is a massive tear on the medial aspect of the groove and on the lateral aspect, including a massive tear of the subscapularis, which is retracted medially. Now, of course, the biceps can enter the joint as shown here. We see this regularly. This is a picture of what it might look like. Here is an example shown here of the biceps tendon. Here is the retracted, torn subscap. By the way, again, this can look like a Buford. It can look like a Glom sign, as we talked about earlier. Whenever you see a rounded region of low signal, always go back and check, is there anything in the bicipital groove? The usual pattern we see, however, is this one. This is an upper axial section through the glenohumeral joint. Here is the biceps tendon lying medial to the lesser tuberosity. There's the empty groove. Here's the subscapularis torn and retracted. That's high up. But as you go down in the axial plane, what often you see is that the lower fibers of the subscapularis tendon are intact. So at this level, the biceps lies anterior to the lower subscapularis tendon fibers. So it travels in the joint for quite a distance and then exits out, becoming located anterior to the intact lower fibers. This is common in our clinical practice. And then finally, the last type, this is an intra-articular dislocation, but the subscapularis mechanism remains intact. We get tears of the medial limb and of the subscapularis, a complete tear, but what happens, in fact, is the mechanism remains intact because of those crossing fibers over to the greater tuberosity. This will allow the biceps to enter the joint without the subscapularis tendon being retracted. This is what it looks like diagrammatically. Here's the tendon slipping over the lesser tuberosity, reaching the joint, but the mechanism remains intact because of these fibers that go over to the greater tuberosity. Here's an example. There's the biceps. This is the subscapularis mechanism intact. And another example, subscapularis not retracted, extending over to the greater tuberosity, the biceps subluxed lying in front of the lesser tuberosity, which is eroded. So subtle differences, but to be complete, I showed you all 6 types. Not to say that we can identify all 6, we try to, but at least we are very, very cautious and yet careful about deciding whether or not the biceps tendon is subluxed at the level of the biceps pulley. And I think when this article comes out, which it should soon, and I think it's AJR, you'll have a better idea of the variability of the normal position of the biceps tendon, and you'll have to compare that information with what you see in any individual patient. Now let me finish up in the last 2 or 3 minutes by just talking about a couple of other entities. The hourglass biceps is a name introduced to describe a markedly hypertrophic intra-articular portion of the biceps, this part, such that when the arm is elevated, it cannot, in fact, move into the groove. So you get this buckling of the biceps within the joint. Called an hourglass because there's the upper part of the hourglass, the constriction, and this was the myotendinous junction. So they call this an hourglass deformity. I will mention it when I see something as dramatic as this, a markedly enlarged intra-articular portion of the biceps, that part below the groove, much more normal, compatible with intra-articular entrapment and an hourglass. Tears of the biceps tendon are generally not hard to recognize. This is a longitudinal split tear. One of the things that I've noticed about these tears, most of them are split mainly in an antero-posterior axis. This one is oblique. That accessory biceps creates a zone of higher signal in a medial lateral direction. So maybe that will help in a few cases, but not always. And then complete tears of the biceps tendon often do not occur precisely at the anchor. They occur a short distance from the anchor. So in these cases, you want to at least look up here, try to find the stump, and we tend to measure it. This can become entrapped within the joint as well, so you should look for the stump. In this example, marked distal retraction of the torn biceps and an empty bicipital groove. So what I've done in this last lecture dealing with the shoulder is to cover a few miscellaneous things.